Welcome to This Explainer. Today, we are stepping into the totally fascinating and honestly incredibly high-stakes world of clinical observation. Have you ever wondered what healthcare professionals are actually looking for when they poke, prod, and ask you to wiggle your toes after an injury? Well, let me tell you, it is not just routine paperwork. It is absolute frontline medical detective work. Today, we're going to decode the neurovascular assessment, which is this absolutely critical set of skills used by nurses and doctors to spot these invisible dangers before they cause any permanent damage.
Okay, let's dive into this. If you, or maybe a loved one, have ever had a broken bone, had a cast put on, or gone through orthopedic surgery, you probably remember that rather annoying hospital experience. You know the one, being woken up in the middle of the night. A nurse comes in, shines a flashlight, touches your foot, and asks you to wiggle your toes. And you're thinking, why on earth do they need to do this every single hour? Are they just trying to ruin my sleep? Well, actually, no, not at all. That repetitive toe check is literally the ultimate tool for limb salvage. They're on the hunt for something very specific.
They are hunting for an invisible, tissue-killing villain called compartment syndrome. You see, our muscles and nerves are enclosed by this tough, inelastic band of tissue called fascia, which essentially creates a closed compartment. It's kind of like a tight sleeve that doesn't stretch. So if bleeding or swelling happens inside that space, the pressure just builds and builds. It starts crushing the nerves and choking off the blood supply. And if that isn't caught early, it leads to muscle ischemia, permanent nerve damage, loss of the limb, or even worse. This is a massive surgical emergency, and the neurovascular assessment is our early warning radar. To really understand how this works, we're going to follow a clinical checklist. We'll be looking at 1. The invisible medical threat. 2. The assessment toolkit. 3. Investigating the upper limbs. 4. Investigating the lower limbs. 5. Spinal surgery observations. And finally, 6. Continuing care at home.
All right, kicking things off with Section 1, the invisible medical threat.
So, recognizing clinical changes early is the absolute key to preventing irreversible tissue death. Medical professionals actually use a vital memory aid, often called the P's of compartment syndrome, to make these critical warning signs sticky and easy to remember. First up is pain. But we're not talking about just any pain. It's pain completely out of proportion to the injury, or extreme pain when the limb is moved passively, or pain that just refuses to go away even with strong opioid medications. Then there's paralysis, meaning you just can't actively move the limb, and heads up, that's a very late and dangerous sign. Paresthesia is next, which is that pins, needles, or tingling feeling you get from nerve compression. Then we have pallor, meaning the limb looks pale and feels noticeably cold because it lacks arterial blood supply. Pulselessness is another late sign that basically indicates tissue death. And finally, swelling or increased pressure, where the skin starts looking super tight and shiny.
Moving right along to Section 2, the Assessment Toolkit.
Now that we know what the enemy looks like, let's explore the core elements of the assessment protocol that nurses run hourly after a high-risk injury. So the crucial point is that you cannot evaluate a limb in isolation. The golden rule of this medical detective work is that you must always compare the affected limb to the unaffected limb. Think about it. Everyone's baseline skin tone, temperature, and pulse strength is just a little bit different. By constantly comparing the injured arm or leg to the healthy one side by side, a nurse can spot incredibly subtle differences that might be the very first hint of early circulatory compromise.
One of the quickest and honestly most effective tools in this whole kit is checking the capillary refill time, or CRT. Imagine doing this on your own hand right now. You press down hard on the nail bed for 5 full seconds. You'll see it blanch or turn white as the blood gets pushed out of the external capillaries. Then you release it and you watch the color rush right back. In a healthy, well-perfused limb, that pink color should pop back in under 2 to 3 seconds. If it takes longer than that, that's a glaring red flag that the limb is just not getting adequate blood flow.
All right, on to Section 3, investigating the upper limbs.
Now, what's really interesting about this slide is how beautifully we can isolate specific nerves, like the median nerve. We're shifting our focus here specifically to the nerves and motor functions of the arms and hands. To check if the median nerve is being choked off by swelling, you check sensation on the palmar surface of the hand. You're looking specifically at the webbing between the thumb and the index finger. Then, to test motor function, you just ask the patient to bring their thumb and little finger together so they touch. Actually, try it yourself right now, just a simple pinch. But that pinch requires an intact, perfectly functioning median nerve to pull it off.
Now, to test a totally different pathway, the ulnar nerve, the nurse will palpate or lightly touch the area between the little finger and the ring finger, checking for any numbness or tingling. And for the motor function test, they'll ask the patient to abduct, or basically spread all their fingers wide apart, often against just a little bit of resistance from the nurse's hand.
If the patient can confidently fan their fingers out, that tells us the ulnar nerve is communicating perfectly.
Next up is Section 4, Investigating the Lower Limbs.
Moving down the body, we're going to apply this exact same logic to look at the specific nerve zones of the feet and legs. Down in the leg, we have the peroneal nerve. To investigate whether it's intact, a nurse will touch the dorsal surface, which is just the medical term for the top of the foot. If the patient can feel that, great. Then they move to the motor test, asking the patient to dorsiflex the ankle and toes. That simply means pulling your toes upward, pointing them toward your shin. If you can pull your foot up like that, your peroneal nerve is firing on all cylinders. In contrast, to check out the tibial nerve, the nurse focuses on the bottom, or plantar surface of the foot. And the motor test here is literally the exact opposite of what we just did. The patient is asked to plantar flex, meaning they push their ankle and toes downward, kind of like pressing on a gas pedal in a car. Being able to do that downward movement confirms the tibial nerve is healthy and hasn't been compromised by any compartment pressure.
But beyond just the nerves, there's the incredibly vital matter of blood flow. Take a look at the major pulse points in the lower leg and foot, like the posterior tibial and the dorsalis pedis. Nurses will actually mark these specific spots with a pen, so they're checking the exact same place every single hour. Now, if pulses feel weak or are totally absent to the touch, they aren't going to waste time. They'll grab a device called a Doppler scan to hunt for even the faintest sound of blood flow. Remember, pulselessness is a late and highly dangerous sign of tissue death. Catching a weak pulse early, that changes everything.
Let's move to and see how this builds in Section 5, Spinal Surgery Observations.
When the central nervous system itself is being operated on, the observation protocol becomes incredibly rigorous. Following spinal surgery, the stakes are phenomenally high. Weakness or paralysis here doesn't just mean a localized limb issue, it could actually indicate spinal cord compression or a major nerve root injury. Because of this, nurses have to assess motor function in both the upper and lower limbs. We're talking fingers, wrists, elbows, toes, ankles, knees, the whole shebang. They compare light touch and even pinprick sensations bilaterally across both sides of the body. Any sudden loss of movement or sensation, or an onset of severe escalating pain, that requires immediate drop-everything escalation to the surgical team to prevent irreversible neurological deficits.
Finally, Section 6, Continuing Care at Home.
Eventually, these patients get discharged, and this intense medical detective work, it gets handed directly over to parents, patients, and caregivers. And there is a terrifying but necessary truth here. A lot of patients leave the hospital before the risk window for compartment syndrome has completely closed. This is exactly why parents and caregivers are rigorously educated on these signs and symptoms. They are specifically instructed that they literally must deliberately disturb their sleeping children at home to perform these color, warmth, and movement checks. I know, it feels so wrong to wake a resting, healing child, but it is an absolutely necessary vigilance to make sure their limb is safe.
So as we wrap up this explainer, I want you to think about what you've learned today. Whether it's an unexpectedly high level of pain, a delayed capillary refill, or just an inability to spread your fingers wide, these small, subtle clues form a much larger picture of vascular health. Knowing those P's of compartment syndrome isn't just for nurses, it's incredibly empowering knowledge for anyone. So I'll leave you with this. What subtle sign might be the very first clue of an invisible emergency for you or a family member? And now, would you be ready to spot it?